You know that feeling, right?
Yeah.
Drowning in information, especially when you're trying to understand something complex like medicine these days. It feels like trying to pull one specific thread out of this giant tangled mess.
It really does. The sheer volume can be overwhelming.
Yeah, exactly. And today, we're going to dive deep into one of those really challenging but incredibly important areas. Rare
A
diseases.
fascinating and often misunderstood topic.
Totally. Now, when we say rare, you might think, okay, affects hardly anyone. And yeah, individually, these conditions are rare, usually defined as less than 1 in 2,000 people.
That's the European definition, roughly.
Right. But here's the kicker, the thing that often gets missed. Collectively, rare diseases impact a massive number of people. We're talking, what, 30 million in Europe?
Around that, yeah. And 25 million or so in North America. It's staggering when you add it up.
It really is. So chances are you probably know someone affected even if you don't realize it,
Yeah.
because their specific condition is just so uncommon. And that brings us to the core problem, doesn't it? It's not just the rarity, it's the isolation. How do you give the best care? How do you do the vital research for conditions that are just so hard to find, hard to study? Patients are scattered everywhere.
It's a fundamental challenge for healthcare systems globally.
Okay, let's unpack this. Our mission today is to look at this really fascinating, carefully built solution from France, their national minimum data set for rare diseases, the FMDSRD. We want to go beyond just what it is. We want to get into how they actually built this thing with national consensus and really understand why it's such a big deal for patients and researchers.
And what lessons we can learn from it.
Exactly. What can the rest of the world take away from this?
Well, it truly is an immense challenge. Think about it. Just in France, you're looking at an estimated 3 to 4 million patients with a rare disease.
3 to 4 million. Wow.
And for many of these diseases, there might be fewer than 100 known individuals in the whole country.
That's an incredibly small number.
It is. And what's fascinating here, or maybe deeply challenging, is the difficulty this creates. Because the conditions are so rare, the actual medical expertise needed for diagnosis and care, that's incredibly rare too.
Right. You might have just a couple of doctors nationwide who really get it.
Precisely. And for research, trying to run a traditional clinical trial with, say, 50 patients scattered across the country, it's almost impossible. So many conditions lack effective treatments because the research is just so hard to do.
So what did France do? They saw this coming.
They did. They recognized this quite early and made it a public health priority. They were really proactive, actually. Their first national plan for rare diseases was way back in 2005.
Okay.
And that plan did something pretty groundbreaking. It set up a national network, 131 expert centers, supported by over 500 complementary units, all focused on specific groups of rare diseases.
So creating hubs of knowledge.
Exactly, building critical mass for expertise. Then their second plan, from 2011 to 2014, put money behind the IT infrastructure needed to actually connect and support this network. That really paved the way for better data.
Ah, okay. So that connects directly to the FMDSRD we're talking about. Because even with these expert centers, they hit a snag, right?
Oh, did. A major roadblock. They found that rare disease patients were often, and this is their term, barely identifiable within the standard hospital IT system.
Barely identifiable. So patients were getting lost.
In a way, yes. Not necessarily lost to care within the centers, but lost to the system. Their data wasn't being captured or coded in a standard way nationally.
Why was that? Just no specific codes.
Pretty much. A lack of standardized coding for thousands of rare conditions, and crucially, no systematic national data collection focused specifically on them. It was like a digital blind spot.
I'm picturing it like trying to find one specific super rare orchid in this enormous messy greenhouse.
Yeah.
You know it's in there.
Yeah, good analogy.
But without labels, without a system, how do you even start to find it, let alone study it or protect it?
Impossible, almost.
So this new data set, the FMDSRD, was meant to be that labeling system, that guide. It had very specific goals, didn't it, driven by those national plans?
Absolutely. 3 key objectives really stand out. First, identify patients within that expert care network to make sure care was continuous, seamless.
Makes sense.
Second, make the actual activity of these rare disease centers visible in the data. This was crucial for them to justify their existence and get funding.
The practical side, money.
Always. And third, and this is huge for progress, help identify patients who might be eligible for clinical trials or those vital cohort studies. Really unlock a research potential.
Okay, so that brings us to the minimum data set idea. What exactly is an MDS? It sounds minimal.
Well, minimal in the sense of defining the essential core data needed. It's much more than just a list of things to collect. An MDS is really a structured scheme of data elements, DEs we call them.
VEs, okay.
Yeah. And the scheme specifies exactly what data to collect, whether collecting it is mandatory or optional, and importantly, any rules for verifying the data. It's about bringing structure, consistency, precision.
To tame the chaos.
Exactly, to tame the chaos of fragmented data. And this MDS approach, it's not brand new. It actually started as a way to manage healthcare costs, but now it's used widely.
Like where else?
Well, good examples are the U.S. Cancer Network, they use MDS principles, or the U.S. Office of Rare Diseases Research, or DR, they have common data elements for their global registry, the GRDR.
Okay, so order and GRDR. Lots of acronyms today.
Haha, yes, welcome to health informatics. It helps to quickly distinguish, though, between a common data element, a CDE that's designed for use across lots of different data sets.
It's like a basic building block.
Right, and a specific data element, an SDE, which is tailored for a very particular purpose, maybe a specific public health measure. The French FMDS-RD cleverly uses both. It's a hybrid. But this raises a really important question, doesn't it? How on earth do you actually create something like this? Especially for rare diseases, with thousands of different conditions and all these different doctors and researchers and hospitals involved.
Yeah, that sounds like herding cats on a massive scale. How did they do it? That seems like the real magic here.
It really is. And you're right, it wasn't a quick fix or some top-down order. The methodology they used is what makes the FMDSRD so impressive.
Yeah.
It was this multi-step, iterative process, really designed from the get-go to achieve national consensus.
National consensus, that sounds ambitious.
Hugely ambitious. But they broke it down. 6 key steps. First, establish several expert working groups.
Okay.
Second, a really thorough, systematic review of all the existing scientific literature on data elements for rare diseases.
Not just a quick Google search then.
Definitely not.
Yeah.
Third, those groups developed a first draft. They called it version 0. Fourth, they sent that draft out in a big national survey to get feedback and formalize it.
Gathering input from everyone.
Exactly. Fifth, rigorous validation by national task forces and strategic committees getting the official stamp of approval. And finally, sixth, standardizing the whole thing into an electronic format, specifically using FHR-RHL 7 standards.
FHR-HL 7, so it plugs into modern systems.
That's the goal, make it interoperable. And crucially, look who was involved. Not just a few doctors, you had medical coordinators from all 131 expert centers.
Wow.
A national task force with experts, government agencies, the Ministry of Health researchers, a strategic committee with public reps, e-health experts for the tech side. This broad buy-in was absolutely essential.
No wonder it took time, but it sounds like they built a solid foundation.
Absolutely. And that literature review you mentioned, let's dig into that because it's revealing. They didn't just search randomly. They identified existing DEs from known catalogs, like the U.S. Order we talked about, EPRAR, Samara in Europe.
Building on prior work.
Right. Then they did a focused search in PubMed using the Human Rare Diseases Ontology that maps over 7,000 diseases combined with keywords like minimum data set or common data elements.
Sounds thorough.
Extremely. But here's the really surprising part. They started with over 2,100 articles. Guess how many were actually useful for defining a general rare disease MDS?
Maybe 100.
6.
6 out of over 2,000.
6. Most articles were way too specific to one disease or group, only keeping very basic stuff like patient ID. It just shows how fragmented the knowledge was and how little existed on creating a truly common language for all rare diseases.
That really highlights the challenge they were up against.
Yeah.
Okay, so after the literature review, they had this draft, version 0, then the national survey.
Yes, and this was key for that consensus piece. They sent it to 160 rare disease experts, including all the center coordinators. It was a big online questionnaire, 118 potential data items grouped into 12 themes.
And what were they asking? Keep it. Toss it.
Essentially, yes. Should we keep this item? And if yes, should it be mandatory or optional? They even had strict decision rules built in.
Yep.
Like if an item got more no votes than yes, it was just out. If it got more yes than no, it was only kept if enough people responded and the yes vote was over 50%. Otherwise, it went to the task force for a deeper discussion.
So quite rigorous. Did they get good participation?
Fantastic, actually. An 81% response rate from those experts, which is really high for something like this.
Definitely.
And the results. Out of 105 specific data element questions, 54 items were kept, 30 were rejected outright, and 21 needed more discussion in a second round.
So a real filtering process.
A real consensus-driven filtering process. And if we connect this back to the bigger picture, that level of detail, that buy-in, is just so vital. It means the final data set is much more likely to be actually used and accepted across all the different medical fields involved.
Right, because a disease might hit the kidneys, the eyes, the brain.
Exactly. And the nephrologist, the ophthalmologist, the neurologist all need to be able to use and understand the data for that same patient using this common standard.
Okay, so after all that meticulous work, the reviews, the surveys, the task forces, what did the final FMDSRD actually end up looking like? What's in the box?
Right, the final product. It contains 58 data elements in total.
58. That feels manageable.
It's designed to be. 42 of those are common data elements, or CDEs, the broadly applicable ones, and 16 are specific data elements, SDEs, tailored more for French national needs.
And how are they organized?
They're grouped logically into 13 categories, makes it easier to navigate.
Can you give us a flavor? What kind of categories?
Sure. Things like consent, really important.
Oh.
Patient identification, obviously. Personal info, family history, vital status, are they okay? The whole care pathway the patient follows.
Diagnosis too.
Absolutely. Diagnosis history, the confirmed diagnosis, treatment details, even specific info related to pregnancy and newborns, the anti- and neonatal information. It captures a lot of the journey.
That sounds comprehensive. Is it a huge burden to collect all that?
Well, here's the clever part. They designed it so that 38 of those 58 elements, almost 2/3, are things likely to be captured and coded anyway within electronic health records during normal care.
Ah, so it fits into the workflow. Less extra work.
That's the idea. Minimize that double data entry headache for clinicians. And technically, as we mentioned, it's built to be HL7 FHIR compatible.
Which is the modern standard.
It's the latest standard for exchanging healthcare information electronically. It uses these modular resources, think building blocks for patient data, family history, encounters, conditions, medications, plus specific questionnaires. Makes integration much easier.
So it's designed for the future, technically speaking. How does it stack up internationally? You mentioned the U.S. ODR system earlier.
Good question. They actually did a direct comparison with the U.S. orders GRDR common data elements, which many see as a kind of global benchmark.
Yeah, they compare.
It was interesting. The French FMDSRD covers about 43% of the US GRDR CDEs at the element level, and where they overlap, the meaning aligns 100%.
Okay, decent overlap.
And looking the other way, the US GRDR CDEs cover about 33% of the French standard, with 96% alignment in meaning. So significant common ground, but also clear differences.
What are the main differences then? What does France collect that the U.S. maybe doesn't emphasize as much, or vice versa?
Well, the FMDSRD puts more emphasis on data about the structure of care, quite a bit on that ante and neonatal period, disease activity tracking, and really detailed diagnosis history and confirmation.
Okay.
It collects maybe a bit less on general demographics or quality of life measures compared to the US GRDR standard, perhaps reflecting different national priorities or healthcare system structures.
So it's not just France doing this in isolation. There's a global push.
Oh, absolutely. This fits into a much broader international movement. You've got big organizations like the International Rare Diseases Research Consortium, IRDRC, and the EU's Committee of Experts on Rare Diseases, USERD. They're all pushing hard for similar standards.
The big push now.
Because the lack of standards is a major bottleneck, there's a real lack of shared ontologies, basically. Everyone using different dictionaries for medical terms related to rare diseases.
Like speaking different languages.
Exactly. And you also have different regulatory requirements across countries about how patient data can even be used or shared. It makes large-scale international collaboration incredibly difficult.
Trying to build a Tower of Babel.
Pretty much. And the challenge is keeping these standards aligned internationally. It's not a one-off job. It needs constant coordinated effort to link up coding systems like Orphanet with SNOMED CT, OMIM, ICD. It's complex, ongoing work, and often incomplete.
But the ultimate goal is clear, right? Get this data captured easily.
Yes, the bedside goal, you could call it. Make it seamless for doctors to capture this essential data right there in the EHR during a normal patient visit. Avoid double work. Create a secure data store. Because even if some data exists in current EHRs, often the quality just isn't good enough for solid research without this kind of standardized approach.
Right. It needs that structure, that consistency we talked about.
Yeah.
So let's recap. We've seen how France tackled this massive challenge, building this national minimum data set, the FMDSRD.
Through that really rigorous consensus-based process.
Exactly, involving everyone from clinicians to government to patients. And this FMDSRD, it's a huge step forward for just finding patients, coordinating their specialized care, and crucially, speeding up research.
Breaking down those information silos.
Yeah. And that goal of interoperability, making the data flow not just for care, but for epidemiology, public health, research that seems key.
It's the foundation.
Right. The FMDSRD isn't the entire answer, maybe, but it's a vital foundation for more specialized data sets down the line and for that bigger picture of international cooperation. So what does this all mean for you listening? It means real, tangible progress in a field where information has just been so scattered and hard to pin down for so long.
Turning chaos into order, hopefully.
Turning that messy greenhouse into a properly mapped botanical garden.
I like that. But, as data collection gets better, more standardized, more international, you might start thinking about the other side of the coin. Well, standardizing data for rare diseases is absolutely essential, no question, for progress, for patients. But it has to go hand in hand with incredibly strict compliance with all the rules, national, international, around patient privacy, intellectual property, and especially informed consent.
The trust factor.
Exactly. Which leads to a really important, maybe provocative thought for everyone. As we push for this comprehensive data for the collective good, for new treatments, how do we make absolutely sure that the individual patient's rights, their privacy, their trust remain paramount?
Especially as these systems get bigger, maybe go EU-wide like they're proposing, or connect globally.
Precisely. Think about initiatives like EPSOS for sharing emergency data across borders in Europe. How do we manage that inherent tension between sharing data for the common good and fiercely protecting the individual's very personal information in this increasingly connected world?
That's a crucial balancing act, isn't it? Something we'll need to keep a very close eye on as these powerful systems evolve.
It's a constant negotiation and one we have to get right.